It is what it is. It is what it is. So I want to start today's live by letting all of us know that, to be honest, it's okay for this to be an uncomfortable period for you. It's okay for you to get up every morning and realize that it's the end of the day and you have done absolutely nothing because you can't figure out your head from your toe. You know, that's normal. That's normal. We are all going through a very, very rough period. We are all going through a situation where the world is different. We are all going through a situation where it's not business as usual, and we will all take a little bit of time to get back to quote unquote normal. We're all going to take a little bit of time to get back to normal. I am doing this live today because I recognize I haven't done a live in a little bit, where I just kind of rap with people and we discuss how this disease is evolving. So I just wanted to bring just to highlight some of the new stuff, just to highlight some of the new discoveries that we are having about COVID-19, and just to remind us that it's okay. It's all okay. Eventually, we would get over this. Eventually, we would get back to normal. Eventually, we would get back to the point where normal is actually better than normal was before. So this is an opportunity for us to kind of do some introspection, to kind of think about how life is, think about what life was like before, and to work towards making it better, whatever that means for you, to work towards making it better, because better is, better for me may not be better for you. So this is an opportunity to do some introspection. Don't be too hard on yourself. Don't be too negative on yourself. Don't be too, there are a lot of people saying, you have to get up, you have to do this, you have to, we're going to get to that point. But right now, I think we are all just experiencing this thing, and we need to take our time experiencing it. So let's talk about COVID-19. So let's go back. Remember, from the beginning, we've been saying that what we have is a new version of the coronaviruses. These coronavirus has been around for a mighty long time. It's been around for a while. The novel coronavirus, which is the version of the virus that popped up late 2019, is what we are working with now. Is what's causing all of this havoc all over the world. The WHO in February, I think it was, officially named the virus SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2, as in it's the second version of a SARS coronavirus, and the disease that it is causing is known as coronavirus 2019, COVID-19 for short. The reality is, we do not know what in heaven's name is happening. We don't. We are all learning about this together. We are all learning about this together. We are all learning about what the virus is, how the virus functions, how it affects our bodies, how it is spread, how long it lives. We are now learning about this. Every day we are learning something new about it. And as a matter of fact, I have been spending quite a bit of time just reading. You have to keep reading, because believe me, the information that you thought you knew 2-3 days ago, it's not the same information that we know now about the same virus a month ago, a week ago, 2-3 days ago, because it keeps evolving. Well, no, the virus is the same virus. The virus is the same. I don't know that the virus itself is evolving, but our knowledge about the virus is evolving. So let's talk about some of the things that have evolved, some of the things that have shifted a little bit since we started talking about this. The first thing, I don't know if you recognized yesterday or day before yesterday, I can't remember what, I think it was yesterday. Our CMO, our chief, yes, the chickens in the background, I live in country. Our chief medical officer in Trinidad and Tobago announced yesterday, I think it was, that a couple of the folks who were in quarantine because they came off of that cruise ship, though many of them we thought we had gotten over the period where we thought that if they didn't experience any symptoms, we thought that they were fine. They recognized, and if I'm not mistaken, they may have actually tested them, and the result was negative for SARS-CoV-2. A couple of those people now have tested positive, and they are testing positive outside of or right at the brink of what we call the incubation period. So the incubation period for any disease is the period between when you are exposed to it. So whether it's a virus, whether it's a bacteria, whether it's a fungi, whatever it is, you are exposed to it. And the amount of time it takes between exposure to when you start showing signs and symptoms to show that you have been infected, to show that you are sick. That's the incubation period. For some time, we have been saying that the incubation period for SARS-CoV-2 is between, most people, they say, seems to start showing symptoms between 3 or 4 days after getting infected and up to 14 days after getting infected. What we are recognizing now is that the incubation period may actually be longer than the 14 days. So when we are looking at how long we need to watch someone before we say, okay, even though they've been exposed, they are not sick, that period may need to be extended past the 14 days. Because if you look at the people who came back from the cruise, remember the Minister of Health was saying that we are at the point where they are going to be fine. If they haven't gotten sick yet, they are going to be fine at this 14-day point. And we are realizing that may not necessarily be true. The other thing that we have to be conscious of is the fact that even though people may not be showing signs and symptoms, even though they don't have the respiratory issues, breathing problems, they may not have any of the regular flu-like symptoms, that there are people who have been infected with the virus. The virus is inside of them, but they don't show any symptoms at all. So those are the ones that we classify as asymptomatic. And when you look at the data from countries that have actually done significantly more testing of their general population, whether you have symptoms or not, which is known as surveillance testing, so I'll talk a little bit about that a little later, those countries do show that in some instances up to 50% of the people with the virus who test positive don't show any signs and symptoms. They don't. And since they have the virus inside of them and they are replicating the virus inside of them, even though they are not showing any signs and symptoms, they can still spread the virus to other people. So we have a group of people, and we possibly have them right here in Trinidad and Tobago, where they don't show any signs and symptoms, but they have it in them. Even those who show signs and symptoms, those signs and symptoms may present themselves after the 14 days. After the 14 days, which we thought was the incubation period. So we still have to be concerned about that. I was reading this morning about the fact that they are now recognized. Said the world is learning about this. So when we have what a lot of the rest of the world has been doing is, even though they are not sharing the personal information about the people with SARS-CoV-2 or with COVID-19, the data about those people have been made public so that researchers can go in and do analysis on the data. So a lot of those people, we don't know who they are in terms of their names and so forth, but we know their characteristics. We know their age, we know their sex, we know their location, we know their signs and symptoms. And they've actually been going back now and crunching a lot of the data and realizing that for many of those people, there are other signs and symptoms that we had not originally thought of. So there are symptoms relating to dermatology. There are people who are now saying that they had what looks like a rash coming up on their hands. There are people who've experienced loss of smell and loss of taste. They're recognizing that the virus may actually be affecting other parts of your body, your brain possibly, your heart possibly, and not just your lungs. So we are going to realize a year from now, a couple years from now, that there are so many other signs and symptoms. Even though we were just looking for the flu-like symptoms, we may need to expand the list of signs and symptoms way broader than just the flu-like symptoms, because the virus is attacking different parts of your body in different ways, and we just don't know. We just don't know. There are also questions about how long the virus actually lives outside of the body. How long the virus lives outside of the body, how long it can live on a piece of wood, how long can it live on your doorknob, how long can it live on your table. There are the research from like one of the cruise ships and so forth. There is also there's also research from that cruise ship that shows that they found the virus alive several days after, almost a month after they thought it should be alive in certain areas. So that is also something for concern, which is why you have to keep cleaning, you have to keep sanitizing, and you have to keep doing those things. There's also new information now about how long it can actually stay inside of your body, because we are recognizing all over the world. Korea was the last place that reported of having people who had COVID-19, went through the whole process, survived it, tested negative for SARS-CoV-2, and then tested positive again after. What's going on with that? We don't know. So it may mean that the people were reinfected, meaning they got a completely different set of virus coming into their body somehow. It could be that even though when we tested you, it tested negative, the virus may have actually been dormant inside of your body for a while, and then something else triggered it to come back out, multiply again, so that you could test positive again. We don't know. The other thing that we've been hoping for is to have developed immunity for the virus. So immunity is your body's response to the virus. Anytime our immune system is the part of our body that is able to fight off any foreign thing. When a virus comes in, our bodies create antibodies, and that is what our bodies use to fight the virus. When we develop immunity, we could develop immunity one of two ways. We could develop immunity naturally, which is we've come into contact with a virus, our bodies develop the antibody to it, so that when that virus comes around again, we don't get sick because our body already knows how to fight against it. That's doing it naturally. Or the other way is vaccines. Those are what vaccines are. Putting a version of the virus, it could either be a live version or a synthetic version of the virus. There are different kinds of vaccines into your body before our body has come into contact with it. So our body knows how to fight against it, to build the antibodies to it, to fight against it, so that when we actually do come into contact with it, we already have the antibodies. So our bodies develop immunity, one of those two ways, either naturally or via vaccines. The fact that people who have the virus were negative, sent home, and got it again is kind of poking a hole into that idea of us developing natural immunity to the virus, because it means that person, because they got it before, because they got better, because they were able to recover, it means their bodies should have developed immunity against it, which means they should not have gotten it again. So that's also important, because we now have to wonder, what is it about this virus that makes us not be able, some of us, not be able to develop that kind of natural immunity? Because honestly, I think a lot of places in the world were hoping that the virus, that if enough of us get it, survive, we would then develop what is known as herd immunity, meaning so many of us would have some sort of immunity that we would prevent it from going from one person to the next. If you're in a room with 10 people and 9 of those 10 people have immunity to the virus, even if that one person gets it, it stays with that one person. It doesn't go to anyone else, because all of the others have some sort of natural immunity or have gotten immunity because of a vaccine. And we were hoping that that would happen with this, but we don't know. And just the fact that some people are getting reinfected, again, I'm using that term guardedly, because we don't know whether they have actually gotten reinfected or whether it is the same virus inside of them that has come back again. That also is a tricky situation for us to deal with, because again, we simply do not know. We also aren't really 100% sure about how it travels and how far it travels. Yes, we do believe that it is the droplets that can, the droplets meaning the liquid that comes out of our nose or our mouth, that is causing us, allowing us to spread it. But we also know that we have micro droplets, so droplet nuclei, that are much smaller and therefore can float around in the air a little bit longer. And we also know that for some people, particularly people who are hospitalized, who have had what are known as aerosol generating procedures done, that forces air out of their lungs up into the outside of them, that the virus then becomes aerosolized. And we also again don't know how far those aerosolized versions of the virus can travel, how long they last, and so forth. We don't know. We don't know. So let me answer a couple questions. What about various strains? Yes, there are various strains of the virus. They seem to be, I think, if not, I'm not mistaken, an alpha, beta, and a delta strain, and even there are tweaks of each of those, alpha, beta, and delta. But there seems to not be much variation among the different strains, although that may be why somebody may have an alpha strain once and then a beta strain become reinfected with a beta strain or something like that. We don't know. We need to do more actual genetic testing of the virus to see if that is really the case. And there really just isn't enough time between when we started and now to have all of those answers just yet. So again, we continue to get new information. We continue to have an evolution of knowledge about the virus. And because of that, it is important for us to really, really listen to the advice that is given in terms of staying separated, staying apart, not congregating, because we just don't know. We just don't know. And because we just don't know, we need to do more to just kind of stay apart from each other. We just don't know. So somebody said the incubation period is 14 days. If no symptoms, we are required to return to normalcy. That is what we've been told before, but then as new information comes about, we do need more. We that may have to be extended. That requirement, that request, that protocol may have to be modified. Talk about the virus being airborne and needs negative pressure. Now that is also important, but I will talk about that a little bit later when I talk about treatment and what is required for treatment, and particularly as it relates to treatment for COVID-19, particularly here in Tobago, right? So I just wanted to highlight those new things. And all of the new things say is that we don't have all of the information, and we're going to keep learning. So you may quickly hear them say that the incubation period has been extended past the 14 days, because it's very possible that it takes more than 14 days. There are going to be people, and we already know there are people who are asymptomatic, so they have it but have no symptoms. So the whole idea of an incubation period doesn't even apply to them, because they are showing no signs and symptoms, or they are not showing the signs and symptoms that we have been looking for. So the whole idea of being symptomatic is as a trigger for us now doing something is not going to work, because there are significant people who are asymptomatic, and we need to figure out how to deal with those people, how to prevent them from passing it on to others. And we don't know, even for the people who have it currently, we don't know whether the body would really develop immunity to it. So those people who have it, meaning they would not have it again, they would not get it again, which would then automatically protect a large group of us. And we don't know, even those people who have it, what the virus does in the body. And even though they may test negative, they may actually then test positive again at a later date. So these are all of the quote-unquote unknowns. These are all of the quote-unquote unknowns. And because of that, I have always been, from day one, pushing for more testing and to think about how we treat COVID-19 differently in Trinidad and Tobago. So let me jump to the testing part of it. So in Trinidad and Tobago, the only entity that was authorized to test for SARS-CoV-2 was, and probably still is, the Caribbean Public Health Agency lab, CARPHA lab. CARPHA's labs have been using very restrictive testing criteria, and they are using the criteria from the WHO. The WHO has basically said that certain, a case, somebody who is considered a case, has to have these specific criteria, and based on the definition of a case, a probable case, a possible case, CARPHA has been limiting who they test. For a very long time, CARPHA has been saying they are only testing symptomatic people. So you have to have symptoms before you get tested. If you don't have symptoms, you will not be tested. Now we are seeing where we are already missing a lot of people, because there may be people who are not symptomatic, meaning they don't have any symptoms at all, and are positive, because we are seeing it in Iceland, we're seeing it in Germany, we're seeing it in all of these other countries where they've been testing more people than just those who have symptoms. So that's one of the things we need to be conscious of. The fact that we have been limiting our testing only to people with symptoms means we are probably missing a whole heaping set of people. We were also limiting the people who, even if you have flu-like symptoms, you needed to have just traveled from wherever, the US, China, wherever, and you're now back here. And you needed to, or if you had not just traveled, you needed to have been in contact with people who CARFA confirmed were positive. Now that means that automatically, you are also excluding somebody who may be symptomatic, who has flu-like symptoms. But because they did not travel, and because they did not come into contact with somebody who the government CARFA says we know has COVID-19, you are not testing them. Which means that if we have community spread here, and community spread meaning somebody has it, somebody is infected, but they don't know where they got it from, they don't know who they got it from, it means that we have been missing those people. So that's a whole other large group of people who we are missing because we were limiting who we test. One of the things that I said from March, if you look back at the last Tobago House of Assembly sitting that we did in March the 26th or 27th or something like that, one of the things I suggested way back then, because we knew that there were asymptomatic people with COVID-19 all over the world, was suggest to the Tobago House of Assembly that we should start surveillance testing in Tobago. What does that mean? So in addition to the people who present normally with symptoms, we should also be testing randomly out there. Let's just pick 1 in every 200 people, 1 in every 100 people. And I actually did the calculation Friday. CARFA said that it's costing about $250 to test using the PCR test. That is a test where they actually look for the virus, the RNA, the genetic material of the virus. Okay? It costs about $250 to do a test. And I did the calculation. If we actually did surveillance testing of 1 in every 100 people in Tobago, that's 600 tests. That rounds up to being $1,050,000. That's all it's costing to test 600 people in Tobago. Now, when we test 600 people in Tobago, it means we would have a better idea, and that's minimum in my mind. We would have a better idea of who actually has it and who doesn't, and we would be able to see whether we do have asymptomatic people here with it, or whether we just have, just the people who are sick and who are showing signs and symptoms. We would be able to say, well, yeah, those really are the only people who have it in Tobago, or we'd be able to say, well, we picked up so from Bell Garden, and we really don't know where he or she got it from, but because we were picking up because we're doing more testing, we are able to pick up those people, because that is what we need. We need to have more and more testing to see. Now, somebody's saying that everybody should say they have symptoms. The thing about that too is that when I understand, even in Tobago, that when we send our samples to Trinidad at CARFA, the wait time for getting a result, it used to be a day or two, which was fine in the beginning. A day or two is great. We know yes, we know no early, no seed. But right now I understand that the backlog is pretty high in CAFA. So it is taking up to more than a week to get back a result. And in some instances, even though the sample is taken, CAFA is saying we are not going to test it. So we have people whose samples have been taken, and for whatever reason, CAFA says we're not going to test it. And this is why I have been saying from day one that we need to figure out how to do our own testing right here in Tobago, because we can't afford, the size of our island, the close-knitness of our island means that we can't use the same rules that they are using in Trinidad to test. We could not, from day one, we should not have been using those to test. We should not have been using. Somebody saying one of my nurses had a fever for 1 day working the ER frontline, and they did not test her because the fever would have to be at least 2 out of the 3 symptoms. So again, even for people who are showing signs and symptoms, they were finding reasons not to test. And yes, Brunzo, the reality is, even if we tested 1,000 people, it would still be much cheaper than Jazz, because I also went on Friday when I did the calculation. 1.150,000 is what it would cost to test 600 people. The 2019 budget for Jazz was $12 million. So $12 million was the 2019 budget for Jazz. So if we are really talking about spending money for something that is important, we already knew we're not having Jazz in Tobago in 2020. We could have decided the money that we had put aside for Jazz, let's use it to test our people here, because we need to. We don't need to test all 60,000 of us. That may not be necessary. It is actually not necessarily necessary. But if we do continually test people, we would have a better understanding of what to do to get it done, to treat with it, to figure out what we do with it, to wrap our minds around it. So on yesterday, I think it was, or maybe the day before, our Minister for Health in Trinidad and Tobago finally announced that they are going to be doing surveillance testing. So I got very excited when I just heard surveillance tested. I said, yay, great, wonderful, absolutely lovely, let us do this. And then I heard, I think a reporter asked, later down, see, that's the thing, you have to keep listening. I heard a reporter ask, so how would it be done, and on who this surveillance testing would be done? And what they said again was that they are going to have one health center in each county, so the different counties or the different districts, I can't remember which word he used. So like there would be one health center in Tobago, for example, that does random testing, but the random testing isn't really random. They are still only going to be testing people with flu-like symptoms. And their idea is they want to see of the people with flu-like symptoms, what kinds of flu we have, whether it is H1N1, whether it is COVID-19 or whatever. So it means they are still not going to be testing asymptomatic people. And that, I think, is an error. That is a mistake. Because again, we are seeing all over the world where asymptomatic people also make up a significant chunk of the people with COVID-19, and we need to have a comprehensive picture of who has COVID-19. And to be honest, if we were willing, I know we pulled it back, if we were willing to randomly pay for security companies to continue, yes, it would be voluntary, Winston. So if we randomly were willing to pay for security companies to help out our police with patrolling and all of that good stuff, it means that we have money somewhere to do this. Because I am sure those 4 security companies were not doing this for free, and I'm sure those 4 security companies were not doing this at a discounted rate. So it means that we have money somewhere So the government cannot say we don't have money because we were willing to pay these 4 security companies to do it, to do their patrol and so forth. So we have money. We can shift that money from those where it was going to be towards those security companies to doing other things, including ramping up testing. Now, the other thing we need to be conscious of is the fact that Tobago seems to be slow on the draw when it comes to doing so many of these things. When the Minister for Health said that they were getting additional PCR machines and that they were now pushing to have testing done outside of the Caribbean Public Health Agency lab, that we were going to use the Trinidad Public Health Lab and Eric Williams Medical Complex Lab, I thought to myself, wonderful, great, why not bring one of those machines in Tobago too? But then the people in Tobago said, no, we don't have the infrastructure, we can't do it, which was, to me, was just so disappointing. It was really, 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 really disappointing, because Trinidad had actually said, the CMO had actually said that they were willing to give us a machine and they were willing to give us all of the resources that we needed, meaning the training, the kits, everything to do the testing. So for Tobago to get that offer and say no was really, really disheartening and was really, really disappointing, to be honest. We have now said that we are sending, so this week apparently we are sending a couple of our lab techs to Trinidad to be trained. But you recognize we are now several weeks later, and we are going to have to wait until another set of PCR machines come from wherever they are coming from. If it's going to wherever they are coming from, for one of those machines to then come to Tobago. That may not be until the end of April. It may not happen at all. So again, while Trinidad seems to be moving forward and using every opportunity to develop and to develop their infrastructure and those things, we are not jumping at the opportunity to develop ourselves here. And because we did not jump at it immediately, it means there is now such a delay in when we could actually start doing it. Now, the other thing that relates to testing that we have to be conscious of is the fact that the PCR machines, though it is the better option for testing because it actually looks for the genetic material of the virus, there now are other antibody tests for COVID-19 that are not going to be as rigid. They're not going to be as correct, for want of a better term. But those other options we can use as a screening tool, and then those who we know or who we suspect based on the screening tool has it, we then send those to be PCR tested. That's an option we need to look at. That's an option, and that is an option that Tobago needs to also look at, because these machines are available in Germany. Yes, we know that they have been having issues with the machines that come out of China, but we've always had issues with stuff that come out of China. The US now has several companies making these different machines. Every day you hear the FDA approving another machine coming out of a different company in the US. So this is something we also need to look at so that we can use our own criteria here, because I'm afraid that if we don't ramp up testing here, we would have such wide community spread that it may be too late for us, and if we don't do it timely, the response to it would be too late, and we can't afford that, because we all know in Tobago that the healthcare system in Tobago is not the absolute best. We all know that. If you've been here, if you've been to our accident and emergency room, even before COVID, we all complained about it. So we needed to ensure that we test people quickly, test people frequently, so that we know who has it, so that we can isolate those people quickly instead of having them continue moving around in the community and continue infecting others. Even those people who are asymptomatic, right? Even those people who are asymptomatic. Now, the last thing I wanted to talk about is treating our patients with COVID-19 in Tobago. I've spoken about it several times, to the point where I guess I've touched a nerve with some people, because the Minister for Health spoke about some doctor in Tobago who's spreading incorrect information, and they needed to set the record straight about what is actually happening in Tobago versus what is happening in Trinidad. And I thought to myself, facts remain facts. Regardless of what people say, regardless of how people try to twist what they're saying, facts remain facts. These are the facts. On the 7th, I think, of April, which was last week, Monday, Tuesday, somewhere around there, our chief medical officer in Trinidad got on television and said categorically, and I haven't figured out how to, I'm not really the best with technology. I was going to play what he said, but I am going to post it in the thing again so that you could hear it for yourselves. What he said was, it was Tuesday, 7th of April, I'm reading it verbatim. He said, "We are not treating COVID-19 positive patients in any of our main institutions. We have seen this happen in other parts of the world where they are treating COVID-19 positive patients within their general hospitals, which basically has resulted in rampant nosocomial spread, nosocomial meal hospital acquired spread within those hospitals to healthcare workers and to other patients. We are trying our utmost best to keep COVID-19 patients treated at Hoover and Cora and any other facility that we identify as separate and parallel to the main healthcare system to ensure that healthcare workers are protected." He used two words, separate and parallel. What do those mean? Separate meaning we have to figure out how to divide our assets. He said specifically, because we have seen, and let me explain why. Let me read something else. There's the vice premier of Lombardy. Lombardy is one of those areas in Italy. The vice premier of Lombardy, his name is Carlo Borghetti. I don't know if I'm pronouncing that right. When talking about lessons that they learned from Italy, because remember, for a long time Italy was the epicenter. Italy was having the largest number of cases, the largest number of deaths, and so forth. One of the things they said, one of the things that Mr. Borghetti said was, and I quote, "The biggest mistake we made was to admit patients infected with COVID-19 into hospitals throughout the region." He further said we should have immediately set up separate structures exclusively for people sick with COVID-19. He continues, "I recommend the rest of the world do this. Do not send COVID-19 patients into healthcare facilities that are still uninfected." And the reason Mr. Borghetti said that is because what they recognized is when you have in a single facility COVID-19 patients and non-COVID-19 patients, in the areas where they have the COVID-19 patients, because they know they have COVID-19, they are using real strict PPEs and that kind of thing. Those areas, they seem to be doing a decent job. However, they've recognized that in the non-COVID side of the hospital, they were picking up quite a large number of new cases, and they couldn't figure out why. It could possibly be that healthcare workers were moving between COVID and non-COVID and not washing their hands properly, not changing their PPE, I don't know. We don't know, and we don't know about this virus. That's the whole thing. There's so much we don't know. It could have been that it was stuck to their shoes. It could have been all sorts of reasons, but they were recognizing that when you have COVID-19 and non-COVID-19 patients in a single health facility, that you run the risk of causing infections where there are non-COVID-19 patients. which is why in Trinidad they did set up Cora and Coover. That's why they set up those places, so that you don't have COVID-19 patients going to Port of Spain General Hospital, going to Eric Williams Medical Complex, going to South. That is why they set it up, because there was this knowledge that if you put in COVID-19 patients with other non-COVID-19 patients, because we really honestly do not understand how this virus works, we are going to get people who are already have comorbidities. Because remember, one of the things we've been saying from day one is that the people who are most likely to die from COVID-19 are those who already have another disease, people who are already immunocompromised, people who already have diabetes and heart disease and lung disease and so forth. They're the ones who are more likely to die from COVID-19. Those are the people who are in hospital. Remember, hospital is where sick people go. We don't have well people just lying around in the hospital. So because those sick people are the ones who are already most at risk for getting really, really bad response from COVID-19, bad symptoms from COVID-19, we need to do everything in our power to keep those people safe. Which is why when he said that, when the CMO said that on the 7th of April, I quickly jumped and I highlighted to you guys, I highlighted to the island, I highlighted it to the country, that we in Tobago are doing the exact opposite of what the CMO said we should be doing. We are doing the exact opposite of what Mr. Borghetti said. That was their biggest mistake. We are using our one and only hospital, to treat COVID-19 and to treat non-COVID-19 patients, and it is a recipe for disaster. As a matter of fact, it should be the reason why we don't use our hospital, because are we only hospital, or are we only hospital? Why are we putting our patients who are at that hospital at additional risk? And I was just going on what I heard them say, because the acting medical chief of staff at the walkthrough that they had the week before very clearly said that they are using the old hospital of the fort for COVID-19 patients who are well, meaning those who don't need to be hospitalized, they don't need medical treatment, but we just want to keep them isolated. They're using up by the fort for those. But the ones who are sick, who need to be intubated, who need to be ventilated, who need care, they are using an ICU in the hospital at Signal Hill, and they are using the medical ward in the hospital at Signal Hill. We have to ask ourselves, Tobago, you have to ask ourselves, because again, we do not understand how this virus works. Because we don't understand how this virus works. We don't understand so many things about it. It means we have to protect that hospital. We have to protect those patients. See, I think I would have been less concerned about it if I did not know that this was such an issue in other places. I would have been less concerned about it if I knew for a fact that every single room in the hospital had their own air circulation system. If I knew for a fact that the ICU that we are using for COVID-19 patients has negative pressure, meaning we are not, the pressure inside the room is lower than the pressure outside of the room, which means that air cannot leave from in the room to go out of the room to go to other parts of the hospital. Is that the technology we have at the ICU at the Scarborough General Hospital and on the ward at the Scarborough General Hospital? Can we honestly truly control airflow at the Scarborough General Hospital? Because it's quite possible that the reason why the other hospitals that tried the commingling, even though they were using separate entities within the same facility, The reason they got infections in the non-COVID era is because they may not have been able to really control the air circulation. Now, granted, we have been saying all of the time that SARS-CoV-2 is transmitted via droplets and it is not in the air. But do we know? We don't. We are not 100% sure. Yes, it seems like it's primarily through droplets. But, you know, the way this thing is evolving, in a week from now, in 2 weeks from now, in a month from now, we may be hearing something else because additional tests were done and we now know a little bit more. Which is why I've always said, let us set up somewhere different, somewhere separate. Now, granted, I don't like the idea of using the old hospital because there is a reason why we left the old hospital in the first place. If the hospital up the fort was good, we would not have left up the fort and built a new one in Signal Hill and moved out of up the fort. So I don't necessarily agree that the old hospital that we all left and we never decommissioned it properly. I don't necessarily agree that that is the best place. But it is what it is. We're in a situation where we have to use the best of the worst, I guess. Whatever. There are other options, and this is why it takes brainstorming. This is why it takes thinking about this differently. There are other options. Yes, we have the Moriah Health Center. That is new. That is not finished and handed over just yet, but because it's not new, because it is new and it's not handed over just yet, maybe we could retweak, maybe we could retrofit, maybe we could do something with that to use that as the center for treating COVID-19 patients. And as I said before, that has the added benefit of being on a field with a lot of space, because I don't know if you've been watching television and watching the internet and so forth, you're recognizing that a lot of places in the US, because again they want to keep that separate and parallel system, they are using these tent hospitals, temporary tent hospitals, where you're putting up the tent on a flat space, you're putting the bed, you're getting the ventilators and that kind of thing, because that's what you need to help people breathe for the most part. So that's an option there. We could use, you know, the Dwight York car park, the Parade Square. It's a nice big flat space. We could figure it out. There, you know, in my mind, there's always an answer. There's always a way to think through these things and to work it out. Now, the other thing that we have to be conscious of is when we talk about separation of assets or dividing assets and not commingling COVID-19 with non-COVID-19, we're not just talking about the physical building space. So that is critical. That is absolutely critical, the physical building. But we're also talking about all of the assets, the furniture. That's a given. Obviously, not taking somebody off of a COVID bed and putting a non-COVID person on a COVID bed. I mean, that's a given. But we also need to think about how we separate the assets of people. And let me explain why. Remember, we have been hearing all over the world that we health professionals are at real high risk of contracting COVID-19, particularly if they work around patients with COVID-19. So when I say separation of assets, we are including the staffing, because you don't want a situation where you are using the same doctors and nurses with patients who have COVID-19 and then sending them over to work with patients who don't have COVID-19. Again, because we are now learning about this. Again, because those doctors or nurses may contract it and are asymptomatic. Remember, if they are asymptomatic, it means that they don't have signs and symptoms. They are not coughing, they are not sneezing, but because they have it, they can still spread it. So that doctor or that nurse can then go over to the non-COVID patients, interact with them and infect them. That's quite a possibility. That's an important possibility that can happen. So when we say separating of assets, we are also talking about staff. You can't have the same grouping of people. And even when you are talking about separating assets, we also have to be critical and thorough with how we scheduled staff working. So for example, if you have a shift of 5 nurses and 2 doctors working, we should continue using those 5 nurses and 2 doctors to continue working in that shift, so that if, God forbid, we do have an outbreak within that group of healthcare workers, we know that the only people we need to pull out of the system are those 5 nurses and 2 doctors. But if we were commingling, meaning allowing them to work and mix them with different shifts and mix different nurses going different places, different shifts, working with different people and all of that, it means that if there is an outbreak in one area, we have now potentially infected the entire system of healthcare workers, because that one nurse may be on the morning shift today in this health center, but on the evening shift tomorrow in another health center, and on the morning shift somewhere else in another health facility. So that person now has been in contact with 3 different groups of people who we now need to possibly pull out of the system. So, these are the things when we're talking about separating assets, when we're talking about ensuring that we're not commingling. These are the kinds of things that we need to do. I understand, for example, that we have hired a bunch of doctors and enrolled nursing assistants and possibly nurses and so forth, which is wonderful. That's absolutely wonderful in Tobago. But even though we hired them, I am thinking, and I'm sure there are others who would agree, that the better use of those people would not be to put them in the system one time. See, we need reserves. We need reserves for our health professionals. So even though we hire these nurses and hire these ENAs and hire all of these people, let's spend this time to train them. We could use them to do telehealth, meaning have them call patients, make sure patients are okay, because we don't want our patients to come into the hospitals or come into our health centers unnecessarily. And if, heaven forbid, we do have an outbreak within the system, we now have a reserve of doctors and nurses out there that are already ready and waiting to go if we need them or when we need them. That's the kind of strategic thinking, and that's the kind of structuring of the system that is necessary to think. So you have this group, that if they are sick, you're just pulling out this group. You don't have to do much contact tracing and so forth, because this is a group that's been working, and you can then just replace that group with another group of 5 nurses and 2 doctors or whatever. Those are the kinds of things we have to think about, and those are the kinds of things we should have thought about. Those are the kinds of things we should have been implementing from day one. So going back to when the Minister for Health talked about some doctor in Tobago giving incorrect information, I'm not giving incorrect information. I am just repeating what was said by those in Trinidad and what was said by those in Tobago, and pointing out the fact that what is happening in Tobago is in direct conflict to what you said should be happening in Trinidad. And if we continue doing that in Tobago, we are setting up ourselves for failure. We are setting up ourselves to not respond to this thing the way it needs to be. We are setting up ourselves to fail, and we can't fail. This is one of those times where we cannot afford to fail. We simply can't afford to fail. Our lives are at risk, so failing is not an option. So that's why I've been clear, and I will keep saying it. And I do not care who talks about some doctor in Tobago who is giving misinformation. Facts will remain facts, regardless of who says what. Facts will remain facts. And the fact is, we have a situation in Tobago where we are planning to use the ICU at the Scarborough General Hospital up Signal Hill, and the medical ward at the Scarborough General Hospital up Signal Hill, when in fact what we should be doing is identifying a separate, separate and parallel system to treat COVID-19 versus non-COVID-19. And there's nothing that anybody could tell me, because I have been to that hospital and I know that As much as they're trying to say it is a separate, and as much as they're trying to say we're using a different entrance, blah, 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 there is no real separation, particularly since we don't really understand how this virus works right now, and we really don't know if a month from now they would come back and tell us, oops, we've been saying it's in droplets all these years, all these months, but we just realized that it is in the air. And if it is really in the air, it means that, oops, we have now infected the entire hospital. We can't risk it. We cannot risk it. And Tobagonians, I need you all to continue standing up. I need you all to continue share. I need you all to continue. Stephanie, negative pressure for... I don't think we do. Listen, and you know why I don't think we do? Because there are... Before COVID-19, we were complaining about not even having air conditioning in these wards. Now, if we are complaining about not even having something as simple as air conditioning in these wards, there is no one who could convince me that a ward where we did not have air conditioning and we could not control the air temperature is now a ward where we can control air pressure. You can't convince me of that. You cannot convince me of that. And I live here long enough to know that I had to lend people fan to go in the wards. Yeah. So you can't now come and tell me that we suddenly have real isolation, because that is the word they've been using. They've been saying that it is isolated, thinking that we would hear the word isolation and assume that it means negative pressure. It may be a way, but that does not make it isolated in medical terms. It does not make it isolated in medical terms. And as a matter of fact, somebody sent me a picture. Somebody sent me a picture of basically a sign that says COVID-19 facility, no unauthorized entrance. And I am wondering if that COVID-19 facility on no unauthorized entrance sign is what we are really using to stop the COVID virus from flying through the air, from passing through. Because remember, if the patient is having an aerosol generating procedure, we are now moving away from the virus in droplets to the virus being aerosolized, meaning in the air. And that is the critical part that we need to be conscious of. Okay, so I think those were the areas that I wanted to touch on for now. I think I am going to do another live where I touch on some of the social issues, because our social response to this has not been the best, and I am going to highlight some of those issues a little later, not today. I'm going to highlight some of those issues. So I just wanted to talk about how the viruses, or how our response, or how our knowledge to the virus has been evolving, about how we should really be doing as much testing as possible, because really that's the only way to get a real sense of what's happening, and not just testing symptomatic people. We need to also test asymptomatic people. And Tobago, even if Trinidad is not doing it, this is the, A&R Robinson, all of our stalwarts fought for the Tobago House of Assembly so that we can make these kinds of decisions on our own. If we really were autonomous, we would be able to say, okay, y'all, in Trinidad, all you do all you want. If all you want to only test symptomatic people, by all means, just test your symptomatic people, but we will spend our money and test asymptomatic people here too. We gonna spend the jazz money, or we gonna spend the whatever money to do it here. We will go out and buy our own machines and so-called, and do what we need to do, because that is what we need to do. That is what we need to do. And that is where I'm hoping our leaders would take the initiative to push and go beyond what is being done in Trinidad. What is being done. And of course, the last thing is, I am going to still keep pushing that we don't treat COVID-19 patients at the Scarborough General Hospital, because it is our one and only main hospital. And at the rate they are going to keep infecting it if we don't do this correctly. As a matter of fact, honestly, at the rate they're going, they may as well just turn the Scarborough General Hospital into the COVID-19 facility and treat everybody else somewhere. But as long as we keep doing that co-mingling, that's a recipe for disaster. So guys, thank you so much for tuning in. Thank you so much for sharing. Thank you so much for giving me your comments. If there are any questions, you can message me. I will try to answer them. I'll do another live a little later in the week, and we would go from there. Again, keep your spirits up. Let's keep pushing. Let's keep doing this. Let's keep at it. Let's keep at it. It's a difficult time. It's a different time. But this is where we could show what we are made of, and this is where we could beat this. We could come out of this stronger. We could come out of this better, and I think we can do it. I think we can do it. Stay home. Stay in all your house, please. Stay in all your house. In my house. The last time I left my house was when I had to go. No, I went down the road and pick up a mango from the road from the neighbor mango tree. But other than that, I'm staying in my house. I am staying in my house. So please, my dear, share the live, share it to other people who may benefit. If there are questions, let me know, and let's keep doing this. All right, bye.